Hi guys, let's start. So questions that confused you, misunderstood maybe, previous several exams, board exams. Let's clarify these questions about amenorrhea. Today's topic secondary amenorrhea. So take your pens, papers, and let's start. So papers and pens, you need to make the notes, of course. Okay, let's go. Pregnancy, my beloveds, is undisputed champion of secondary amenorrhea cause. The single most common cause of secondary amenorrhea in women of reproductive age is pregnancy. Of course, I am kidding. It seems obvious, but its prevalence means it must be ruled out first in every workup, regardless of the patient's reported sexual activity, so-called, or contraceptive use, so-called. Missing a pregnancy can have significant consequences for both patient care and potential fetal health if contraindicated medications or procedures are considered. So what's clinical issue of that? A sensitive urine of serum human chorionic gonadotropin, HCG. Test is the standard initial step. That is, relying solely on patient history, so lady's history, is insufficient. Remember that, my beloveds. Definitely, the brain holds the reins. So one of the major causes of secondary amenorrhea is functionally hypothalamic amenorrhea. This isn't a structural problem, but a functional suppression of the hypothalamic pituitary ovarian axis, HPO axis. HPO, it's, remember that, HPO, it's a hypothalamic pituitary ovarian axis. Okay? Okay. Hypothalamic pituitary ovarian axis, HPO. Often due to stressors like excessive weight loss, extreme exercise, often there go both, or significant psychological stress. So the hypothalamus reduces its pulsatile secretion of gonadotropin releasing hormone, GnRH, gonadotropin releasing hormone, GnRH, remember, HPO is a hypothalamic pituitary axis. So why it's so important, my beloveds, clinical issue? This leads to decreased LH and FSH, luteinizing hormone and follicle stimulating hormone, release from the pituitary, resulting in low estrogen levels, so-called hypoestrogenism, and failure of follicular development and ovulation. So why it's, my beloveds, why it's so important? Recognizing functional hypothalamic amenorrhea is crucial because management focusing on addressing just on underlying stressors, that is nutritional rehabilitation, so low carb but low proteins and lipids, normal drinking water, etc. Low carbs, modifying exercise, stress management, if it's possible, of course, rather than just hormone replacement therapy, especially initially. Never hormone replacement therapy in functional hypothalamic amenorrhea, especially initially. Polycystic ovary syndrome is the most common endocrine disorder among women of reproductive age and very frequent cause of secondary amenorrhea, or more commonly oligomenorrhea in frequent periods. While often associated with irregular cycles, it can present as full amenorrhea. Clinical issue of that. So polycystic ovary syndrome is typically characterized by a combination of oligo or anovulation, so infrequent or absent ovulation, clinical or biochemical signs of hyperandrogenism, that is excess male hormones, and polycystic polycystic ovarian morphology on ultrasound, though not required for diagnosis if the other two criteria are met, Rotterdam criteria. So its importance extends beyond infertility. It's linked to insulin resistance, type 2 diabetes mellitus, dyslipidemia, cardiovascular disease, actually all metabolic syndrome chain. So all this requiring, of course, long-term health monitoring. Absolutely. About bone density. Secondary amenorrhea, particularly when caused by low estrogen states like functional hypothalamic amenorrhea or premature ovarian insufficiency, POI, poses a significant risk to bone health. We know that. So estrogen is crucial for maintaining bone mineral density. Mineral density. Prolonged hyperestrogenism leads to increased bone resorption over formation. Why it's so important? So this can result in osteopenia or even osteoporosis, increasing fracture risk later, especially in menopause. In life, assessing for and managing bone health, for example, considering hormone therapy, ensuring adequate calcium, vitamin D, recommending weight-bearing exercise where appropriate, actually always appropriate, recommending weight-bearing exercise is very good advice. So assessing for and managing bone health is a critical aspect of care for women with chronic hypoestrogenic amenorrhea. Dual energy X-ray absorptiometry scans may be indicated depending on duration and cause. Measuring serum FSH and LH levels is fundamental in differentiating the level of the problem with this HPO axis. The pattern provides vital clues. So, for example, low normal FSH and LH ratio with low estradiol suggests a hypothalamic, like functional hypothalamic amenorrhea, or pituitary cause, hypogonadotropic hypogonadism. So means the ovaries aren't being stimulated properly. High FSH and LH, so often FSH more than LH with low estradiol, strongly suggest ovarian insufficiency failure. Now hypergonadotropic hypogonadism, such as premature ovarian insufficiency, if under age 40, 40 minus. The ovaries aren't responding to pituitary signals. And, for example, normal high LH ratio with normal high LH with normal follicular stimulating hormone FSH ratio. Now often LH FSH ratio more than 2 or 3. So characteristic, though not, of course, not diagnostic alone of polycystic ovary syndrome. About headaches, you will get this question. You will be asked. No, I think you will be asked about that. So, my beloveds, elevated prolactin levels, that is hyperprolactinemia, are a relatively common cause of secondary amenorrhea. Prolactin inhibits the pulsatile secretion of GnRH from the hypothalamus, disrupting the HPO axis. The most common cause of significant hyperprolactinemia is prolactin-secreting pituitary adenoma, prolactinoma. Therefore, measuring serum prolactin is a standard part of the secondary amenorrhea workup. If elevated, it warrants further investigation, potentially including magnetic resonance imaging or MRI of the pituitary. Importantly, large adenomas, so-called macroadenomas, can cause mass effects like headaches or visually field defects. So classically bitemporal hemianopsia due to heminopsia, up to you how to pronounce. So bitemporal heminopsia due to optic chiasm compression. Chiasm compression. Making secondary amenorrhea a potential presenting symptom of a treatable brain tumor. Actually, thanks God, often manageable with dopamine agonists like cabergoline or bromocriptine. Cabergoline, bromocriptine, up to how to pronounce it. When the uterus is the culprit. Sometimes the HPO axis and ovaries are functioning perfectly, but menstruation doesn't occur due to an anatomical problem within the uterus itself. Asherman syndrome refers to the presence of the intrauterine adhesions, scar tissue, that obliterate the endometrial cavity, often preventing menstrual bleeding. Why it's so important? This typically occurs after uterine instrumentation, so iatrogenic problem, most commonly dilation and curettage, DNC, especially after pregnancy, postpartum, or unfortunately post-abortion. Never do this abortion. I will find you. Or in the presence of the infection, endometritis. Diagnosis is often made via high hysterosalpingography, HSG, hysterosalpingography or hysteroscopy. Diagnosis of this problem, not to see mechanical defect. It's an important consideration in women with secondary amenorrhea who have a history of uterine surgery or your procedures. Treatment involves hysteroscopic resection of the adhesions. Thyroid disorders, both hypothyroidism, no, of course the most common, hypothyroidism, and less commonly hyperthyroidism can cause menstrual irregularities, including secondary amenorrhea. The link is complex but involves interactions within the endocrine system. So why is it so important, my beloveds? In primary hypothyroidism, low thyroxine T4 leads to increased thyroid stimulating hormone, TSH, and potentially thyrotropin releasing hormone, TRH, from the hypothalamus. High TRH levels can stimulate prolactin release from the pituitary, leading to hyperprolactinemia, which, as noted earlier, suppresses GnRH. Thyroid hormones also have direct effects on ovarian function and estrogen metabolism. Checking TSH is therefore a routine part of the initial secondary amenorrhea workup, as thyroid disorders are unfortunately common, but fortunately treatable, often restoring absolutely normal cycles. While some causes of secondary amenorrhea involve outflow tract obstruction, like severe Asherman's, the vast majority of cases reflect an underlying problem with anovulation. Regular menstruation, my beloveds, remember that, regular menstruation as well as pregnancy. So normal pregnancy. And regular menstruation is a good outward sign of regular ovulation. No, pregnancy of course, but regular menstruation is generally good outward sign of regular ovulation. Anyway, remember that, my beloveds. So pregnancy is something luxurious. If lady got normal pregnancy and breastfeeding, so means everything's okay with her organs. So she's healthy. She's okay. That's why, and by the way, that's why I have to ask these questions. Doesn't matter what narrow specialty you will choose in your future medical practice. So ask about duration of pregnancy, how many pregnancy, duration of breastfeeding, all this is absolutely important. As well as regular menstruation is a good outward sign of regular ovulation, and by that, good sign of health. Remember that, why it's so important. So therefore, secondary amenorrhea is a primary symptom investigated in female infertility. Understanding the cause of the secondary amenorrhea is a paramount to addressing the infertility, not only in the fertility, of course. Whether it requires lifestyle changes, for example, functional hypothalamic amenorrhea is the core of the problem. Ovulation induction medications, for example, like clomiphene citrate or letrozole, often used in polycystic ovary syndrome. Treatment of underlying conditions, thyroid disease, mentioned above, prolactinoma, or assisted reproductive technologies. No, it depends. Actually, the last one is I don't like, but anyway. So you will ask about that on the big exams questions, of course, on a board exam. And question that professors adore on your big jury exams, board exams. So my beloveds, it's a symptom, not a diagnosis. It's the imperative of thorough workup. Perhaps the most crucial point is that secondary amenorrhea is not a diagnosis in itself. It's rather a symptom indicating an underlying issue, underlying cause. Dismissing it without investigation can lead to misdiagnosis of potentially serious conditions, pituitary tumors, metabolic syndrome in polycystic ovary syndrome, premature ovarian failure with associated health risks, etc. and so on. So why it's so important you understand? The systematic approach involving a thorough history, including stress history, weight changes, exercise, what else? Medications, obstetric, gynecologic history about abortion. Physical exam, looking for signs of hyperandrogenism, galactorrhea, thyroid abnormalities, and targeted laboratory testing, HCG, FSH, LH, TSH, prolactin, sometimes why not estradiol, testosterone. So all this is essential to uncover the etiology and guide appropriate management, which varies drastically depending on the cause. So finally, it's all, That's all. Yes, that's it. That's all concerning secondary amenorrhea. I suppose I clarified all questions that misunderstood by you, maybe misunderstood, maybe confused. I don't know. Thanks for your attention. Don't forget to follow and subscribe my Dr. Y YouTube channel, as well as my Telegram Dr. Y channel, the same name. Dr. Y, it's me. No, of course, mine is a name. Dr. Y. So you tap in searching mode in Telegram. It's a private channel. So what to do? Easy peasy. You tap in searching mode in Telegram. Dr. Y. Doctor. No, doctor like doctor. Y like question, W-H-Y, no, without question mark. So Dr. Y, you type in searching mode, you click start, it's a bot. You click start and you choose your plan. And then we will talk privately. God bless.